Welcome to the 8 Minute Rule. I'm joined by two fellows and a fellow in training. Welcome, Lucas. Glad to have you on your first episode here, so we're glad you could join. Drew and Mark as well. Good to have you guys back. Again, we're getting rid of the fluff right now. We just want to get some good clinical content out to everybody, things you can use in the clinic. We believe one of the greatest preventions of burnout is being able to get success with the patients you're working with. So I want to just be able to bring some good content to everybody in our company from guys that are doing it well in the clinic. So today we are talking about lateral elbow pain. It's funny, I know for me, and I think you guys probably see this as well. You may see a bunch of it, and then you may go a month or so where you don't see much of it at all. So you want to be sharpening your skills consistently, but also having things to lean back on. We know the latest CPG, I believe, is 2022. What I'm going to do is post that in Teams so everybody's got it available in front of them. It's a great toolkit. It's got some good breakdowns of things that you can look at. Overarching, we have some pretty good evidence for manual therapy, exercise, dry needling for chronic lateral elbow pain. As far as acute goes, not quite as good evidence there, but we do know once we get things calmed down to where they can start loading, we see a lot of benefit. It also had mentioned that the pain-free grip test was more relevant than the max grip, which was something that I actually need to check up on myself because I'm doing oftentimes max grip on that. If you want to dig into that more, let me know. We can. But really using the pain-free grip test is a really good, relevant way to monitor strength and improvement there too. So good test, retest that you can use. All right, so what I'll do, my timer is broke, but we're going to still throw 8 minutes out here. All three of these individuals are going to get some feedback about what they're seeing in the clinic and what they're doing with it. So I will start the timer now. And if you would, Mr. Lucas, give us an update on kind of what you've seen and what you've had some success with in the clinic here.
Lateral elbow pain is one of the few handful of pathologist pains that can throw the clinician and patient through a loop. It's usually challenging, as most of tendinopathy contractile tissue conditions are. Takes a little bit of time, takes the finding where to lead. My take in what I teach is, like, as a physical therapist, we need to stop treating the medical diagnosis and treat the dysfunctions. What I see the most is the improvement comes when you find the dysfunction to be treated. I have been doing more and more very detailed differentiation assessment of conditions like tendinopathies, specifically of the Achilles, the tibialis posterior, the lateral elbow being one of them. I recently had a chef. He owns his own restaurant. He cooks 7 days a week, basically, and has been to a really good physical therapist, someone I trained myself, and didn't get much of improvement. I didn't accept the diagnosis of lateral elbow pain, and I went on a differentiation process of which tendons, if any, is this a contractile, is there a joint problem, joint mobility, joint instability that could come up with some cues for me to be working with that patient. And with that assessment, with that sequencing, I found out that stabilizing the wrist was one of the biggest steps to be taken in that specific case, followed by a sequence of exercise and adaptation for day-to-day activities, specifically the cooking activities that he had. We had five visits, 2.5 weeks, and he was about 75% better after this approach. Now, would I take the same approach to another cook in another situation? I don't know. I think the take home here is we needed to stop and do a proper differentiation assessment of what are the aggravating factors and tackle the dysfunction that we're finding.
So Lucas, I want to get these other guys' opinion as well too. But you said this individual was not getting better where he was going. What's kind of your quick assessment? What was he doing that you feel like was also a barrier? Because it seems like you did less is more in this situation. But just a little quick plug. What do you think was the barrier there?
Soft tissue mobilization, including dry needling, um, movement with mobilization. So he was doing the
A lot of the
squeezing the
standard things
ball
that we're
with
doing. Yeah.
right. Yes, basically what the clinical practice guideline was
Okay.
is it talks about, right? So he was doing mobilization with movement. He was doing isometric. He was doing some modifications in his cooking, but he couldn't modify because the pain
Yeah.
wasn't getting better. So he's having a difficult time modifying, right? One thing about clinical practice guidelines, which is clinical practice guideline is a great tool for us, but we can't forget that the clinical practice guideline is nothing but a meta-analysis of studies,
Hmm.
and these studies don't necessarily take individual cases into consideration. They put everything into a statistical analysis, right? It
Yeah.
is a statistical regression analysis that brings up what they recommend. Correct. That doesn't mean it's what we should do. So that was a good case to exemplify what I'm saying.
Yeah,
Yeah,
Lucas,
I think
I love that idea. Treat the patient, not the diagnosis. Go ahead, Mark.
yeah, I was to say I think that's a good point because, and it goes to the whole clinical reasoning mindset. If doing your standard, lateral elbow stuff isn't working, then we need to shift gears and look at something else. And Lucas decided to look kind of down the chain at the wrist, and I think there's a lot of value there that I probably miss. My bias is that I tend to look up the chain at the shoulder and the cervical spine. And that's where I'm usually going to go first. Usually, lateral elbow stuff is a factor of something going on at the shoulder that's causing them to move in a specific pattern that's putting abnormal stresses through some structures. And then, there's a ton of research that even doing some small, quick treatments at the cervical spine can downregulate the nervous system and decrease or increase pain pressure thresholds at the lateral elbow pretty immediately.
I'm I'll jump in, but I was gonna say I also tend to go more proximal first, uh, and see a lot of people with lateral elbow pain with a lot of deficits in shoulder and cervical spine, and that also follows a lot of the research. Um, and the other thing that I found it interesting that the stability portion, I tend to see probably more issues in the wrist with lateral elbow pain with like an extension type issue. So I mean that's another place to look, but I think it goes to the point of that regional interdependence of hey we have our um, guidelines of what we want to do, and one of the primary things is to load the tissue. But how do we get there? Looking up and down, whether it's cervical, creating a window of opportunity by doing maybe some thrust manipulation at the cervical spine, where they can load more, stabilizing the wrist, where they can start to load a little bit more. Trying to remember where it was, but all roads lead to loading it. Um, and I think that's a key point is how can you do it? When you're talking about the mobilization with movement ones, I think the lateral lateral glide of the ulna is one of the main ones that is typically used. Recently, I've seen a little bit more of doing a radial head glide, like a P to A, can also ease that. So even looking at um, different mobilizations in order to try and decrease the the pain while you're trying to load is a key piece, I think, as well.
Um, well, tell me a little bit more about A to P, P to A there. Um, Drew, what is that about exactly? Why were you in a A to P, P to A at that
Of the
phase?
radial head.
Yes.
Honestly, initially it was because the lateral glide didn't work, and we did a little P to A glide. Now maybe that looks at there's some potential lateral instability, um, but either way, you can start to potentially load and help stabilize and progress the strength of that lateral elbow pain.
Yeah,
And it's an easy thing that they can typically do at home.
right.
Uh, a P to A with the radial head is a little bit easier sometimes than the lateral glide of the ulna. So sometimes it's a little more relevant for home exercises with that patient.
Yeah, I think to that point, I know we're running on time here, but I think we often neglect the actual joints in the elbow. Whereas, like if someone has an Achilles tendon thing, oftentimes we're looking at talocrural joint, maybe the joint above, and even subtalar. But for the elbow, for whatever reason, at least my bias is that I often neglect the actual elbow joint. So proximal radial ulnar, and then humeral radial and humeral ulnar joints. And a lot of times there's some things there that need to be cleaned up to help them get better.
Agreed.
Yeah, I think that's a good word. And yeah, as you said, P to A to P, it matters. But like everything else, if one way is helping, or if the one way is not working, try the other way. And you can usually get a pretty good feel for it. One of the things I've also seen in clinic that's been helpful, using kind of the pull-up assist bands and stepping on them and having them put pressure just on the forearm, so you're kind of getting essentially a downward glide depending on your position. But with the arm out in front, trying to work pronation, supination. I know the supinator and the biceps really have seen to be something that helps control a lot of this, and you can get a lot of pain-free rotational motion to the elbow there as well. And I think it continues to drive home some of the things you guys are talking about. But I appreciate the whole bucket here together, which is obviously treat the person, not the diagnosis. There's times where less equals more, and we keep pounding on the things that the CPGs say, but if our patient's not getting better, we need to pull back a little bit and either look up the chain, down the chain, or pull back a little bit and see can we get them tolerating load a little bit more. So really good stuff. And as you guys said, we're at time. Yeah, go ahead, Lucas. Last thought.
Let me just get one more thing here. So if you're still working on everything, you're looking outside the box, retesting things, and checking further into a sequencing of clinical reasoning. The spots that you have to look into is the gripping mechanism, and specifically the chef I'm talking about. I could change the width of the grip of the pans and pots, right? I could create another form of handle for the patient to do that. I've done that before. Specifically, tennis elbow is well known. It used to be known as a tennis elbow, right? You need to check the pressure on the strings of the racket of the player, as well as you can change the grip of the racket, or medial for the medial elbow. You can change the grip of the golf clubs, if you will. Those things cannot be unchecked, cannot go without an assessment.
Yeah, so really digging into what are they doing on a daily basis. That's going to give you a lot of information there. So, all right, well, I appreciate it, fellas. Good stuff. And again, everybody, comment in teams for us. Give us some feedback. We'd love to keep the conversation going. Appreciate you guys putting this together, and we'll see you next time.